Hello and welcome back to Pediatrics Case of the Day. I'm Brandon Brown, pediatric radiologist at Riley Hospital for Children at Indiana University Health. And today's case is a prenatal diagnosis of left abdominal cystic lesion. Now I was a little tricky with that history because I didn't say when the cystic lesion was identified, and before I get to it I want to show you the very first prenatal ultrasound image of this patient, which was obtained at 16 weeks gestational age, which is pretty early, but we can see that there's a normal appearance to the kidneys labeled left and right here on this mid-abdominal ultrasound. And importantly, we don't see any cysts here at 16 weeks. But then on a follow-up prenatal ultrasound at 23 weeks, we can see that things have changed. So just for point of reference, the fetus has changed orientation. The red arrow marks the spine. And we can see that there are new cysts in the left abdomen. There's a large dominant cyst with smaller cysts around it. And we don't really see any normal left renal parenchyma. Now the white arrow, the smaller white arrow, does indicate that right kidney looks about the same. But initially, the obstetrician who obtained this image felt unsure whether these were dilated loops of bowel, and so they ordered a fetal MRI. And on fetal MRI, we can see here at 30 weeks a redemonstration of those cysts. We've got coronal and axial fluid-sensitive images, and we can see the cysts isolated to the region of the left renal fossa. Again, the right kidney looks pretty normal. We don't see a dilated ureter. It looks like the anomaly is isolated to this one region. So based on these images, a diagnosis of a cystic anomaly of the left kidney was made, and on neonatal ultrasound, we get more of the same. We get this appearance of cysts replacing the left renal parenchyma. Importantly, we don't see a renal mass or tumor. And also, we don't see a typical hydronephrotic picture with a dilated, identifiable collecting system. And our final image for this case is an 18-month postnatal ultrasound, which shows that cystic collection has decreased in size. There's an involution going on where each individual cyst is smaller, there's less of them visible, and there's no blood flow in any residual renal tissue. So when we put all of these images together, this is a pretty classic presentation for a multicystic dysplastic kidney. Now there are two different types, and the primary type of MCDK is a failure of development. So if you recall, the ureter has to grow backward up into the kidney, and it has to connect with the renal tubules. And if that process gets arrested, the renal tubules can't empty, and you begin to get a dysplastic change to the kidney. But there's also a secondary type of MCDK, which is due to a focal obstruction that occurs somewhere in the urinary tract. Can occur anywhere, although we talk probably most frequently about a ureteropelvic junction obstruction. And over time, as urine is unable to empty, there are consequences to chronic obstruction, and you begin to get dysplastic changes of the kidney. And the final appearance of both primary and secondary MCDK can be identical. Now, one question you may have asked when you were looking at the case initially was, why is it that we have these normal appearing kidneys on the initial 16-week ultrasound? And I think that's an important question to answer, and the answer has to do with that distinction I just described. So this is a case of secondary MCDK. This is a post-obstructive change to the left kidney, and it's important to remember the timing of events prenatally. So we usually don't see the bladder until 15 to 17 weeks, but some authors have described seeing it more around 20 weeks. So at a 16-week ultrasound, it's very possible that the kidney just hasn't accumulated enough excreted urine to start to see the sequela of a chronic obstructive effect. But then on later ultrasound and of course on MR images, it was quite clear that there were consequences. Now, just for comparison purposes, I've put together the ultrasound appearance of severe hydronephrosis and MCDK. The important difference is communication of the cystic structure. So in hydro, of course, they're communicating because we know they're not really cysts, they're just dilated calyces and the pelvis. But in MCDK, there is no communication between those cystic structures. And then a secondary difference would be the presence of renal parenchyma, the cortex that we can see there marked by the red arrow. It's a little thinned, but it does have a clearly identifiable appearance. But in MCDK, often we don't see anything at all, and if we do see some tissue, it's echogenic and scarred. So there's a clear difference there. And then here I've put 3 side-by-side coronal fetal MR images, just demonstrating the difference between the quote-unquote cysts that we'll see prenatally. So in hydronephrosis, we have communication. Again, in MCDK, no communication. And then in so-called polycystic kidney disease, we don't see cysts at all in the typical presentation, just enlarged and hyperintense kidneys on MR. So when you hear about perinatal renal cysts, and I don't mean an isolated cyst or two, that's sort of a separate topic, but a diffuse process of cystic disease, there's only a few things to think about, and they're pretty easily distinguished. So if the cysts communicate, it's hydronephrosis. If they don't communicate, it's a multicystic dysplastic kidney. And if we're talking about polycystic kidney disease, the recessive form does present early, prenatally, but we don't really see cysts in the vast majority of cases. The dominant polycystic kidney disease does show cysts, but it doesn't really present at this age in most patients. It's something that's going to show up later in life. So it's easy to sort these things out and to be able to figure out what we're dealing with. So to recap, key features for MCDK, we're talking about either a congenital process or the effects of chronic obstruction, primary or secondary disease. And we have non-communicating cysts in a disorganized pattern, often that have completely replaced the renal parenchyma. You want to look on the other side of the patient because a contralateral anomaly, either another obstruction or some sort of anatomic defect, are frequently seen. And finally, in terms of treatment, there's not much we need to do. This is something that's going to spontaneously involute. Maybe we'll follow it with some serial ultrasounds to make sure we have our diagnosis correct. And there are no other secondary effects, but half the time these are going to be gone in early childhood anyway. No surgery required. Thanks for tuning in to our case, and be sure to follow all the case of the day from Indiana University Radiology on Twitter, either through my Twitter account or Dr. Nicholas Kuntz, and be on the lookout in the near future for a case from Dr. Daryl Heitkamp.